And now we have instructions on language access. This meeting is being interpreted in Spanish, and it's also being interpreted in American Sign Language. I encourage everybody to select, once we turn on the interpretation, that you select and go to the interpretation icon and select the language that you would like to listen to. Select Spanish if that's your language, or select English. And now I will read the instructions in Spanish. La siguiente presentación tiene servicio de interpretación en español. Y para iniciar esa función, haga clic en el icono de interpretación, que es el símbolo de un globo o mundo abajo en su pantalla, y seleccione Spanish o español como su idioma. Y para escuchar solo el audio en español, haga clic sobre Mute Original Audio. And while we turn on the interpretation, now I'm going to ask Ben to please read the closed captioning instructions, as this meeting is also being closed captioned. Ben?
Great, thank you, Maria. So yeah, we also have closed captioning available. You should see the logo CC underneath it. Should say live transcript or closed caption at the top or bottom of your screen, depending on which device you use to join us today. If you click that button and select show transcript or show subtitles, you'll see the captions pop up on the bottom of your screen. If you need to adjust the caption size, you can go into your settings. On the sidebar, you will see a option for accessibility, and then you can drag the slider to make your subtitles smaller or larger. We also do have our ASL interpreters. Thank you to Katie and Pamela. They will be spotlighted throughout the meeting, so you shouldn't have to do anything. But if you do have trouble, you can always try and find their picture. Select the 3 dots that in the blue box that pop up when you highlight their video, and then click spotlight or pin. And I will pass it back over to you, Maria.
Thank you, Ben. So a few Zoom housekeeping reminders. We ask that you please mute yourself when you're not speaking, and to speak slowly for interpreters and captioner. And also we ask that you use the Q&A box to ask questions so that everyone can see them and we can track when the questions are answered. And that also includes for the members of our public who are also watching this webinar. So please, if you have a question that you'd like to address to the group, please put it in the Q&A box. And I will now pass it on to Greg Hodge, one of our co-chairs.
Good afternoon, everybody. Thanks, Maria. It's great to see everybody today. We want to get started, as we always do, welcoming you to this meeting of the Community Advisory Group on September 14th. We always take a moment to acknowledge the land that we're on, as our Native American relations and friends would say, you know, this is a lonely country, and we're here through the good graces of our ancestors and others. We also want to acknowledge all of our ancestors from whatever community we come from. There were people who worked and struggled and laughed and cried so that we could be here. And so we give honor and praise our ancestors. And in particular today, you know, we want to acknowledge just for a moment one of our friends in this work, Daryl Allums, who is one of the leaders of Oakland Frontline Healers. He lost his son to a car accident over the weekend. Daryl has been very active in all this work, and we know that his family is hurting right now. So we just wanted to keep that family in our thoughts and prayers today as we do. And then lastly, if we just take a moment for all the folks who have passed over this last couple of years, 18 months, 19 months, due to the COVID pandemic. And we know that it's still serious. We're going to talk a lot about what's going on with our children in schools today. Here's some highlights from community as well as from our public health partners in this. And so if we just take a silence for all those folks who have passed over this last period of time, and then we'll get going. We just take a moment. Well, thank you all very much for that. I'm going to turn this over again on behalf of myself, Nestor Castillo, who is the other co-chair, as well as Kimmy Watkins Tart. Thank you for all the work you're doing, all the things we're doing to keep our community safe and healthy. So I'm going to turn this over now to our good friend Kimmy, who is going to lead us in terms of some partner updates. Hey, Kimmy.
Hi, and welcome everyone to our Community Advisory Group meeting. I want to remind everyone that over the course of the months that we have been in this space together, we've used this time to hear from you all about the work that you're doing. We have used this time to hear feedback on the work that we're doing, to raise questions, give us thoughts, give us direction, better direction, clearer direction around how we should go about the work in our COVID response. And so a lot of our time tonight is going to be devoted to both giving information, but also asking you questions about what do you think about the approach we're taking? What else should we be considering? What have we not thought of? And so as we go through sharing information, please keep those things in mind. One of the things that we also talked about early on is that we wanted to make sure that we created space for youth and young people. And so at our last meeting, we wanted to hear from the Umoja Youth Mobilizer group, Youth Mobilizers crew. That's what it is. And so we have dedicated a significant portion of time to hear from this group. Umoja Health Partners is comprised of a mix of community members, advocates, activists, representatives from local community-based organizations, healthcare and governmental agencies, and academic institutions. Umoja Health provides COVID-19 testing, resources to mitigate the spread, care for families and households with a positive family member, and COVID-19 vaccination. As vaccination demand has waned and is particularly low in the 18 to 30-year-old population, Umoja Health launched a Youth Mobilizers crew to promote vaccine awareness and uptake in the 18 to 30-year-old resident group of Alameda County. In partnership with the Healthcare Services Agency, Umoja hired 2 youth leaders for the Youth Mobilizer crew. I am pleased to introduce Kania Johnson and Saher Khan, who are leading the project and will tell you more about their work. Thank you.
Thank you so much, Kimmy. That was such a beautiful intro and description of the program. So, hello everyone. My name is Kanaya Johnson. I am a lead for the Umoja Health Youth Mobilizers, and I also work with the Black Cultural Zone as a event coordinator and marketing coordinator.
Hey everyone, I'm Saher. I am super excited to be here today. I just graduated from University of California, Irvine, and I'm excited to be working with Umoja Health. I also work with GCA, Global Communications, which is a Pan-African resource center that works to get people vaccinated and give resources to the Pan-African community.
So, again, we just had a great overview of how the program was formed. So when we kind of came about, we as a group and as youth in the age group that we are trying to target it, we decided on what we heard from our peers and what we wanted data on and what were our ideas of fighting back. Next slide, please. So we created a survey. And in that survey, we have some uncomfortable questions and we have some general questions just for data collection. And so we decided on going to these emoji pop-ups and trying to see if while people are getting vaccinated or tested, we can, one, figure out the problem of youth not getting vaccinated, and two, figure out a way to fix this issue. Next slide, please. So we decided to show you guys some of the data that we have collected so far. We decided that age was a very important response. And so as you can see, there are some people who did the survey who were not in the target age frame, but we definitely value everyone's opinion as we are trying to just figure out what we can do better to educate people. And so we had some people 15 and it went all the way to 56, but as you can see, 17, 19, 30, 28, 26 are all very high numbers for us. So we're getting very accurate data. We also decided to show you the gender. And so as you can see there, it's kind of half and half with the male and female. We did want to respect everyone's choice of what they're calling themselves. And so we added a few other options. And if people were uncomfortable answering, they were able to say that. And it was only about 7% of people who were uncomfortable answering that question. Next slide, please. We also wanted to show you the zip codes. So as you can see, most of everybody we targeted was in the Alameda County, but because we're at events, we can't really control if everybody actually is in Alameda County. So there's a lot of 94621 because most of our pop-up events are in Oakland. But as you can see, we have touched a lot of the Bay Area. And then this question was it was something we debated about, if we should ask, are you vaccinated? If it was too personal, if it actually did not go with any laws. Like, can we ask this question to people? How comfortable would they be? Would they answer it? But once we started to do some of the surveying, we realized that a lot of people were actually vaccinated. And we also realized that a lot of times when one person is vaccinated in the house, everyone is vaccinated in the house. And so as you can see, only 9.7% of the people declined to answer. Only 26% were unvaccinated, which they gave us reasons on why. And then 63.4% is vaccinated. So for the survey findings, these are the households and people basically either getting vaccinated with their families, not getting vaccinated. And so the first column, you can see 69% of the people that are vaccinated, whole household is vaccinated. There's about 20% people where some people vaccinated. And while I was doing the surveys, I realized that a lot of the sum came from people having children in their home, and the children aren't able to get vaccinated right now. And so that's a good reason, right? And then none was for people who either their whole family is opposed of the vaccination, or they live with a child and then they're not vaccinated. Living alone, so there was an option that if you live alone, maybe you don't live with other people and it didn't apply to you. So you can see that was pretty low. A lot of people do live with other people, but people that were living alone were also vaccinated. And then, as you can see, some people declined to answer. And so another great question was, even if you're not vaccinated, even if you are vaccinated, do you know where to go to get vaccinated? And so as you can see, most of everybody knew where to go to get vaccinated. It was really high, 93, 92%. It was about a 5% rate of people not knowing where to get vaccinated. And, you know, as we did the survey, if they said they didn't know where to get vaccinated and they shared that with us, we definitely told them about Umoja. We showed them where to get vaccinated because we were doing it at the pop-up. So we were able to point and say, you can get vaccinated now, you can know more information now, you can get tested. And if not, here's a card. We have so many more pop-ups. So this question was very important. It went with the vaccination question. So not only did we want to know were you vaccinated, but we wanted to know what were some of the elements keeping you from getting vaccinated, or some of the elements keeping your friends from getting vaccinated. I know myself, I'm vaccinated, but a lot of my friends aren't. So we found that a lot of people are afraid. That was like one of the top ones. People don't know what the side effects look like. People do not have enough information. The information that they currently have are a lot of rumors and a lot of misinformation, which comes from a lot of social media, lack of access to, again, quality information. It wasn't more of lack of access to the vaccine, but they felt like there's not enough information. We're scared. We don't want to die from this. We don't want to grow an extra toe. We don't want to be the guinea pigs. So that's what a lot of we were hearing back.
Thanks so much, Kanaya. So I'm just going to give you guys a couple of recommendations that we came up with up to this point based on the data from both the surveys and the social media aspect of our work. So the most important insight I feel like we've gained is that we need to continue to fight back with well-developed positive messaging surrounded vaccination. There's so much misinformation out there, and it influences people's decisions on whether to get vaccinated or not. As a team, we realized that the only way to combat this misinformation is with consistent, clear messaging of our own. We can do this by being honest and transparent with the people that we're trying to reach. If our messages are designed around sincere stories about people's lives and how they're personally affected by COVID, how the vaccine is keeping them and their families safe, and then we can back up these stories with current data and push these messages out consistently on social media platforms and spaces where our target audience will see them. I feel like this will give us a better chance of coming across and relating to them. If we have to remember to be patient and respectful when going out and conducting the surveys. We realize that people have really strong opinions about COVID and the vaccine. It means that we just need to be careful, consider where they're coming from before we approach them with suggestions. We discovered that instead of attacking their belief systems or offering incentives, we want to come from a place of support that says, hey, we care about you, we care about your health, this is why you should get vaccinated. Lastly, we want to increase credibility on where the vaccine comes from and why we believe it works. So through the data, just like Kanaya said, one of the main reasons people choose not to get vaccinated is fear and mistrust of those who are advocating for the vaccine. So some ideas that we came up with to kind of fight this is that we talked about the type of messages we're using and sending out those messages through credible messengers. I know some of you guys have probably heard this term before, but a credible messenger is someone that the community trusts and will listen to. We want to increase the youth-created content that's pushed out, which we feel like will work better than the messaging that's out about vaccination right now. We've talked about ways to do this. 2 ideas that we've been developing include a video about how the vaccine was made and the process that enabled the public health department to create the vaccine so quickly. So I don't know about you guys, but I haven't really seen, I've yet to see somebody who actually worked on the vaccine speak about it. And I think that that would really increase credibility and trust. So we also talked about creating a short animated clip that explains what the virus or what the vaccine does when it enters your body, the path it takes, how it works. This way we can answer a lot of people's questions calm their fears, and we can deliver this information in a way that's easy for them to understand. So just like for you guys to picture, it'd be like a small little vaccine that's like, hi, I'm the COVID Pfizer vaccine. I'm injected into your body and this is what I do. So after we develop these videos, we want them to be seen by a lot of people, because the messaging that's out there right now is so widely spread that we want our content to be just spread just as widely. So I wanted to share a video. I don't know if it's showing up in the PowerPoint or if we can play it. It's about a 2-minute clip.
We would love to have you play it. I'm not seeing, I'm seeing all the photos of everyone. So Maria, can we assist in some way?
Yeah, we will cue it up.
Okay, great.
Great. So basically the video, what it is I'm sure many of you guys have seen one part of the video. It's a short clip from a side-by-side debunking. The original viral video is a woman named Christina Parks, who is speaking at a public hearing for the Michigan House bill concerning the COVID vaccine requirements. And oh yeah, this is the video. Let's go ahead and watch it really quickly.
And I know last time I got some technical assistance about sharing my audio. So if we run into that issue again, I would appreciate the assistance with that.
Also, Maria, this seems like the beginning of the video. And if you could play it from maybe like 3:45, that would be great.
Okay.
And then we'll watch up to like 6:09. Perfect.
Okay. And then I believe I have to do one more setting, right? So that you could hear my audio.
When you select share screen, when it shows you all the different screens you can share inside a box, under that dialog box, there's a button that says share audio. You have to click that.
Okay. Thank you all, you're bearing with me.
No, thank you so
Here
much.
Here we go. And share sound. Okay, I think we're there.
That these vaccines have no ability to prevent infection by and transmission of the Delta variant.
That's not true. She said that it's concerning and that vaccinated people have similar viral loads to unvaccinated people, which is an inaccurate statement. Let me explain. So when people are referring to viral load, you have to make sure they're actually referring to what viral load means, which is the amount of infectious virus in a sample. When people talk about viral load and they're only talking about PCR or the CT value of a sample, that's not viral load. That's viral genome copy number. That's not the same thing. So far, no one has done experiments testing the actual amount of infectious virus that is shed by a vaccinated person versus an unvaccinated person in the context of the Delta variant. So we can't make any real definitive statements on viral load when it comes to Delta variant and vaccinated versus unvaccinated. But like I said before, the data that we do have highly suggests that COVID vaccines still reduce the transmission of Delta variant. And those data remain true no matter what the CDC director might say.
Do the vaccines prevent the virus from infecting and replicating in the nose and nasopharynx? No. They've only been shown to prevent that replication in the lungs. They're different. The mucosa is very different than the lungs. It's very different than the blood. You inject it to the blood, you make antibodies in your blood. The virus isn't infecting your blood. It's infecting your mucosa, and you don't produce any IgA to neutralize it.
Okay, look. IgA antibodies are the kinds of antibodies that appear in your mucosas. So in your nose and throat, for example.
Maria, you can go ahead and pause.
Researchers have even measured the amounts of IgG and IgA.
Thank you so much. So I just wanted to share this video with you guys because Our goal here is to have the youth create meaningful content and messaging surrounded COVID-19. So to do that, we have to first look at what messaging is out there right now. This is quite an alarming video, and I like the back and forth that he is doing to really pinpoint the things that she's saying, because she bombards us with so much information. So I like the way that he's addressing it. I think this video is a great example of what we're trying to achieve. With the Youth Mobilizers crew, we want to spread consistent, accurate messaging that will appeal to all ages, specifically 18 to 30, which is the demographic that has shown significantly lower vaccinations rates. As he said in the video, people that, like Christina Parks, they're making an attempt to regress the progress that like the public health department has made so far, based off ideas that are really founded in fear and ignorance. And what's worse is that because of the wow factor of her videos, if you could go back one slide, one before the picture. Sorry. Oh, perfect. Yeah, the wow factor of her video, it's shared so much more than the videos that have like the facts. So that's why what we're trying to create is a interactive way to put this information out there, because we have all the right information, we just need to share it. So we hope to create our own debunking videos, working with our own experts, Dr. Noha and Dr. Latif, in hopes of targeting the rest of the misinformation out there. Some other things that we've been working on as a team include conducting social media polls, which is just a quick way to gauge how people are feeling and increase emojis engagement. So the social media platforms we're currently using are here, so please follow us. We would love your support. You can follow along with what we're doing. Thank you so much for your time. That's, I think, all we have today. If you guys have any questions, please let us know.
Thank you. Thank you, thank you, thank you. So I am certain that we have questions. And Maria, please help to keep me on time. So how much time do we have left in this segment?
We have about 3 minutes.
Oh, that's not very much time. Okay, so we'll have a couple of questions. So indulge us a little bit, because I want to be able to ask a couple of questions. I'll take a question from our panelists first. If you don't have a question, I have a couple in the queue waiting. So anybody want to start with a question?
Yeah, this is Greg Hodge. I've got a question. And first of all, can I and Sahir, thank you so much for your leadership and the work that you're doing. We all appreciate it and very impressed by it. If you know, I noticed you did the breakout of gender. Did you notice any differences between what female identified people versus male identified people thought in terms of reasons that they don't get a vaccine? In other words, are like guys more likely to get it than young ladies or folks who are gender fluid? I'm just curious if you notice any differences at all across gender.
There weren't many differences. I will say, I think the females were more just afraid and needed more information, and the males were a little bit more like, I'm not going to be the guinea pig. The government is not going to come for me, and my family said not to do it. I'm not going to do it.
Thank you.
No problem.
Got it. Another question. Well, I have one question, and I can't see all the hands. Greg, do you see any questions? Any hands?
There are no hands right now.
Okay, I have one question I'd like to pose. You mentioned trusted messengers. If you thought about some of the people who you interviewed and wanting to bring information to them, are there examples of trusted or credible messengers that are more relatable, specifically for individuals that might even be in your circle who are not vaccinated?
Yeah, so we actually did a poll with our youth mobilizers about who they thought were good trusted messengers. And I can just share some of the answers that they gave.
Yeah.
We talked about athletes in the community that are trusted. We talked about Steph Curry. We talked about Klay Thompson. We also talked about community leaders or activists. Alicia Garza, who's the founder of Black Lives Matter. We talked about local musicians, people like Mr. Fab, who comes out to a lot of the events. So people like this, we're very open to who we want to hear, what the community, who they trust. And then we want to like utilize that and maybe reach out to them. So we're open to suggestions, but those are what we had in mind.
Excellent, excellent. And one last question that I had related to, you mentioned a little bit about incentives. And the public health department, along with a lot of other, health providers, are rolling out incentives. And we have heard that the incentives could potentially backfire with young people. How do we roll out an incentive program? Just your thoughts, and ensure that it doesn't backfire though with young people. It won't backfire with everyone, but we keep hearing that it might with young people.
Yeah, I don't know, Kanaya, if you also want to weigh in, but I have heard personally a lot of pushback against the incentives. It's kind of more of a sentiment of why are they giving us free stuff to get the vaccine? So that's why we recommended coming from a place of more like sincerity. But I wish I had a chance to like talk about this with my youth mobilizers about rolling out an incentive program that wouldn't backfire. But I'm just thinking right now, maybe thinking about something that would like a scholarship maybe, or like something that would help with school, something that's not so much like Six Flag tickets or like Dunkin' Donuts or Starbucks, like something that's more meaningful or like also related to healthcare. But yeah, maybe those are just some ideas I had.
Excellent. Well, we would love to partner with you all to give us ideas of how to support increasing vaccine uptake with young people and not, have the whole incentive thing backfire on us. And so I'm looking forward to us working together, hopefully.
Thank you so much.
We are as well.
Thank you so very much.
Thank you.
All righty.
Okay. Good evening, everyone. Let's go to the next slide, please. So, good evening, everyone. I'm Nick Moss, County Health Officer. Really appreciated that presentation. Some brief updates on where we are with the summer wave. So overall, things have improved. Daily case rates down about half what it was at our peak, 13.6 per 100,000 county residents per day. Test positivity has dropped, even as testing has remained at very high levels. Our hospitalizations have improved. We had as many as 240 people in the hospital at our worst point, down to 171, and 53 in the intensive care unit. But keep in mind, parts of California, particularly the Central Valley, still with a lot of people in the hospital. The overall system is still strained, so not out of the woods yet by any stretch. Case rate has remained higher in our, that's fine, you can go on to that slide. Case rate has remained higher in our unvaccinated residents compared to our vaccinated residents, really throughout this summer surge. Next slide, please. The other thing I wanted to highlight were case rates among children. That's been an area of interest. We've added this panel to our dashboard. You can look at case rates by different age groups. And this is just children up to age 17. What you're seeing here is the winter surge and then our summer surge that we just got through. So what you can see is we certainly did see cases in children this summer, not to the levels that we saw over the winter, with the exception of the 5 to 11-year-olds that did reach a little bit higher rate this summer than they did in winter. There was a lot of testing in kids with the return to the school. And you know, I think kids maybe mixing more than they were in winter as well. So could be a combination of testing and transmission behind these numbers. But the other takeaway is that case rates are dropping in all of these age groups, even with now 3-4 weeks of school in some districts. So that's good news, and we'll keep an eye on this and all our rates. Hopefully we'll continue to see these decreases. Next slide. Just brief check-in on variants. You know, it's really, the Delta has been the story this summer, but the most recent data from across the state and across the country, it's, you know, virtually 100% of the sequences that are the variants that are identified. Remember, only a portion of cases actually get sequenced, and that portion gets smaller when we have these big surges. But the state, I think, did 14% of sequences of cases in July got sequenced, and in August is still happening, but virtually all of those have really been Delta. Now we do have in Alameda County, and certainly in other parts of the state that's been seen, we have a handful of other variants that are in the news right now, Lambda and Mu, very, very small numbers, but they are here. We're watching those. I think as it's hard to predict what the impact will be. Delta is really, really spread very efficiently in our communities, and hard to know what variant will emerge next, and what we might see with the next wave this winter. Next slide. During that we now have a lot of information, real world information about what happened with the summer Delta wave. This is data the CDC published on Friday. They published several studies looking at how successful the vaccines have been at limiting infection, hospitalization, and deaths. So 5 times reduction in the risk of infection for vaccinated people. We've seen similar numbers here, a little bit different, but in the ballpark. At least a 10-time reduction in risk of hospitalization, and at least a 10-time reduction in the risk of death. So vaccines really holding up through the Delta wave. And I think also we've seen locally what the combination of masks, indoor masking, and high vaccination rates can do to differentiate you know, the impact of COVID versus other parts of the country where those things were maybe not as you know, vaccine rates are lower and mask use is probably lower. I believe that this maybe was covered in the last meeting, but just a reminder, there an additional vaccine dose is recommended for immune compromised persons who received an mRNA vaccine series, that's Pfizer or Moderna. No recommendation yet for Johnson & Johnson. Everybody really is expecting or waiting to see something. I think there's just been less data. But for people who received the 2-dose vaccines who have a compromised immune system, and CDC provides a definition for this, although providers can also make a determination for individual patients that they should get an extra shot. And in Alameda County, you can access, if you're an immune compromised person, you can register and access vaccine through our county sponsored sites. It's a self-attestation process. You do not need a doctor's note to do that. We do encourage people to check with their healthcare provider if they're not sure, if they have a healthcare provider. So that's additional doses for immune compromised people. Next slide, please. The other big topic is booster doses. So we are still awaiting FDA authorization and CDC guidance about booster doses. That is additional, that is for, the idea is that if people are reaching, the vaccines maybe are having less effect over time in some groups, perhaps all groups, that they will need a booster dose of vaccine. And I think the data is still a bit mixed on this. We haven't seen all the data from some of the pharmaceutical companies. We should maybe learn more later this week. FDA is going to meet on Friday to talk about authorizing this for at least for Pfizer, might be a little bit longer for the other companies. And then we expect to hear from CDC's Advisory Committee on Immunization Practices later in the month with guidance about this, but really some I think open questions about who will be the first groups for which boosters are recommended. And we are, of course, always going to continue to prioritize reaching unvaccinated residents, reaching our priority neighborhoods, making sure people at highest risk of severe illness are getting booster shots. But we're certainly in process for planning for a range of possibilities in terms of booster doses. And with that, I will turn it over to Donata.
Dr. Moss, as we're waiting for Donata, there's a question in the chat around the nomenclature that has caused some confusion. Can you clarify the difference between additional dose and booster dose, please?
Sure. And this is confusing, and frankly, I think it's a little academic in some quarters. You may not. Some other jurisdictions, I don't think, have bothered to make a big deal about this, but the CDC has said the additional dose is for people who have compromised immune systems and therefore were unlikely to have mounted a sufficient immune response with the primary vaccine series. So another way to think about it is that they probably should have got 3 doses to start with as their initial vaccine series. Boosters are something that when you get a vaccine over time, if it wears down, it starts off with good protection, and that protection wears down over time. You get a booster dose to boost up your immune response. And so that's a little bit different idea. That's and the question is, when do we need boosters and for whom for COVID, that we're still really waiting for guidance on.
All right, thank you for the next slide. Apologies, I was on mute. So this is a screenshot of our vaccination dashboard that you can see on our website. On the top left, you can see that we are almost at 90% of our population age 12 and up that have received at least 1 dose. And then 76.3% are fully vaccinated. You can see in the second box from the left, doses by age group. The yellow bar represents fully vaccinated and the blue bar those who have received at least 1 dose. When you look at the doses by race ethnicity, that's that third box from the left, you can see that our African American population is still lower than the other groups. And then on the far right, you can see the doses based on location. The right column of that box represents fully vaccinated, and it's roughly sorted from highest percentage to lowest. So you can see which locations have the highest vaccination rates versus the lower ones towards the bottom. Next slide. And for our 12 to 17-year-olds, we have roughly 121,000 in that group. And they have received at least 1 dose, 98,000, and fully vaccinated, 82,000. So we still have a little bit of work to do here, but estimated about 23,000 that are still unvaccinated. So this is an approximation of the numbers of unvaccinated by race ethnicity. I think these numbers are a little bit inflated based on the previous slide, but it gives you kind of a rough estimate of where we still need to do work. And basically, overall, there is still some work to do in our 12 to 17-year-old population with a Latino Hispanic with the highest rate of unvaccinated based on this graph here. Next slide. And then this gives you an idea of where these unvaccinated 12 to 17-year-olds live. We still have a high unvaccinated group in Oakland. Livermore, you can see about 2,300, as well as Hayward, and then you can see the rest of the numbers there. So we're continuing to do outreach in those areas by census tract and using the DOOR project, as well as leveraging some of the state resources, this California Vaccinate 58 resources to reach folks door to door. Next slide. This is a quick overview of really where all of our vaccination efforts are. These are the two main buckets that we have left. If you remember, many months ago, we had the mass vaccination. Now we're really focused on our healthcare system, providing much of the vaccine, and our community mobile vaccination efforts through our public health department also carry a bit of that, but it's much lower. It's about 10% of the overall vaccination efforts. So you can see there on the top, the healthcare system is private practice, pediatrics, and once we get an emergency use authorization for 5 to 11-year-olds, we're hoping that our private practices can assist with vaccinating those youth, community health centers and our hospital systems. And then our public health efforts include our stable vaccination sites. We have those 3 listed there on an ongoing basis. We have pop-up sites, so school, faith-based organizations, businesses, and these are submitted through our interest form that we've shared in the past. We also have contracted partners that you can see there. Those are just some of them, not all of them. And we also have at-home vaccination efforts that are ongoing. Not only our contracted partners are doing those, but also our own public health. We have a very small team that goes out to do that on a weekly basis. But just overall, we are continuing to look at very census tracked, very specific data to really get to those unvaccinated folks in our communities. Next slide. We talked earlier a little bit about incentives. We are rolling out our incentives program this week. We are starting with our stationary sites this week, and we're hoping to roll it out to other pop-up sites in the future. But really the goal of this is to hopefully get a few additional folks to our pods to get vaccinated. And we're hoping to serve about 5,000 to 6,000 residents. Next slide. And then finally, for the vaccination update, this is on our website. So you can see where all the vaccination pods are in our county week by week. So you can see that on our website. Next slide. In terms of our community testing, we have had a higher testing utilization in Hayward and in our unincorporated areas. The highest positivity rates have been in the Native Hawaiian and other Pacific Islander, and also the Latinx and Latino community and the African American community. And again, our testing locations similar to our vaccination locations are on our website. Next slide. And then just to give you a quick overview of what's happening in terms of our outbreaks with our COVID division. This is a graph of our long-term care facility outbreak data. So here you can see that we had very few cases from March to the middle of June. And then we started having a slight increase kind of up and down over the last about 2 months. But overall, this is very low compared to what we saw before our vaccinations came out. And we are working very hard with all of our long-term care facilities to make sure they have access to vaccine. But we had, this is very low compared to what we saw much earlier. And our SNFs are doing actually very well, our skilled nursing facilities, because they have a very high vaccination rate. And we're now really seeing some outbreaks in like adult daycare facilities where they were not operational during the shelter in place and now are coming online and are needing some support to manage any outbreaks. And then the final slide, next slide, gives you just an overview of the different types of outbreaks. So the top curve on the top is our workplace outbreaks. So we're still seeing quite a few outbreaks, but again, it's much lower than we saw even a month ago. And our children, youth congregate settings, we think that may be a little bit underreported because schools are still trying to staff up and be able to report those cases and contacts. But we've seen very few cases in our healthcare settings and very few cases in our unlicensed care facilities, our homeless setting. So, and I believe that is my last slide. Yep.
So I want to pause just to take one or two questions of either Dr. Moss or Donata Nilsson, actually Dr. Nilsson as well, from their presentation.
Dr. Kimmy, I see there's a question in the chat. Any data on people being reinfected after recovering?
So I mean, I can start, but then Dr. Moss, why don't you go ahead? I saw you light up.
Oh, sorry. Yeah, slow to unmute. So, reinfection happens, and I think that how much it's happened with the Delta wave, I haven't seen a lot of data on yet. I think we'll get more of that, but you know, it certainly is a risk. I am not aware of anything, you know, any sort of takeaway points around sort of severity or long COVID or anything like that with reinfection. People do have some, you know, some natural immunity after infection. We've seen that, and I think the question that has come up is that the same as vaccine immunity? And so far, we just don't have enough evidence to show that they're equivalent. And there's some evidence, including a recent study out of Kentucky, showing that actually vaccination is better protection against reinfection than just prior infection without vaccination. So lots more to learn about reinfection, but it happens, and we'll probably see more of it.
Great, thank you. I see another hand. We have time for one more question, and then we'll move on to our next segment, which is our schools and safe learning. Aaron?
Yeah. Dr. Moss, good evening. Good to see you. My question was in regards to the booster versus a third dose, and just to distinguish between the both. I think for me, when we look at Pfizer, right, it's what 30% of an ml, right? And when we look at Moderna, it's 100 of an ml, right? Is that correct? I'm probably not saying it right, but the point being is, do you think that the dosage will be the same, both for Pfizer and Moderna?
Yeah, I mean, I think this is where we really need, this is where like clinical trial data really helps us in terms of, you know, what dose makes the most sense, and you know, what it offers in terms of benefit, and whether there's any additional safety concerns. And I think we just don't have a lot of that yet for boosters. So, you know, I don't know the answer, but I'm hoping that as part of these FDA discussions later this week, we'll get some more data that speaks to some of those kinds of issues.
Okay.
Okay, thank you. So I'd like to now turn it over to Lisa Erickson and Michelle McDonald to walk us through the work being done in our schools. Thank you.
Thank you, Kimmy. Good evening, everybody. Michelle, I don't see you. Oh, there you are. Okay. Team approach. Here we go. Next slide, please. All right. So we thought tonight we would just go over some really quick kind of high level guidance around the schools, especially the guidance that people have kind of been, that the schools have been struggling with the most. But before we do that, we wanted to just highlight how we're all working together in partnership through this whole COVID response. So Michelle, why don't you go ahead, and actually, Michelle, you should introduce yourself before, which I failed to do.
I everybody. Michelle Smith McDonald from Alameda County Office of Education. And I am a regular on this call and appreciate the opportunity to present and talk to you all about our schools and the opening of the school year. So let me just start with the role that ACOE is playing right now. We are working in deep partnership right now with our friends at Public Health. I talk to Lisa multiple times a day, every day for the last 18 months. And so we are, and with many other folks at Public Health. So this is a very, very tight partnership at this point. So ACOE's role is supporting schools and districts in supporting the public health and following the public health guidelines. We have been facilitating and preparing guidance that's been provided by the state at various points. We've had 2 versions of our guidance document. We had one for the 2021 school year that ended up with 38 versions and 60 pages. And we retired that document in the form of something that might be a little bit more lean and mean and rely heavily on more links, but we are still keeping an iterative guidance document ready to go for all. We are connecting families and staff with vaccine opportunities over these past months, working directly with Public Health on the COVID liaison training and outreach to our stakeholder groups. We have another COVID liaison training, I believe it's our 5th one coming up on Friday. And we are also supporting our district with testing options and helping them to build their infrastructure around testing. And then I'll go to Lisa.
So we are doing, as Michelle said, partnering very closely with ACOE and the districts and schools, really working around the guidance, trying to make sure that, schools understand the often confusing state guidance. We're also doing a lot of coordination internally between our Centers for Healthy School and the Center for Healthy Schools and Communities and our Public Health Department. And just, trying to be available pretty much all day long through our Safe Learning line and in partnership with our special setting outbreaks team to make sure that we're here and ready to support schools through this whole reopening, through fall, in the reopening this fall. So moving on to the layers of safety. So this is a concept that CDPH, California Department of Public Health, talks about a lot, and they call it the Swiss cheese approach, which basically means that there's all these different layers that schools are working through and using these safety measures. And sometimes it's impossible to have them all in place, which is why it's kind of a Swiss cheese model. So if the more that you have, you're kind of eliminating those holes, right? And so sometimes, for instance, I'll give an example at lunchtime, maybe kids aren't able to wear masks while they're eating, but during that lunch, they might have really good ventilation and fans, and maybe they're distancing or maybe even eating outside when they have to take their masks off. Next slide, please. And so now we're gonna talk a little bit high level around some of the guidance, and we're gonna go into what has been challenging for schools and how schools have been addressing some of the challenges. And then we want to, at the end of this presentation, get a little feedback from all of you, and we're happy to answer some questions. The first area is masking. So I think most of you are probably familiar. The state and local health departments require masking indoors for all K-12 schools and childcare settings, and outdoors is recommended. And many districts are actually requiring masking outdoors. And the CDC, recommends that people that are not fully vaccinated wear masks outdoors when there's high transmission, which we have right now in our community, when it's, crowded outdoor settings. And sometimes in school, we can end up with crowded outdoor settings at recess while they're waiting in lines. So many districts are requiring the outdoor masking. And, exemptions are children younger than 2, and there's obviously medical conditions that would exempt masks, hearing impaired, and work-related risks. So Michelle, you want to talk a little bit about, before we move to the next one, a little bit about, we're going to do the challenges on each slide and kind of how they're addressing it.
Yeah, we'll call this the real talk section because I really want folks to understand what the circumstances are for our schools right now. So, we've gotten a lot of questions, obviously Public Health and ACOE, about the lunchtime period in particular. The mask rules, indoor classrooms seem to be going really well. I have teacher friends. We have superintendents we're speaking to, that the kids are very adept at leaving their masks on. There isn't nearly as much mask policing as I think perhaps people would have anticipated. We also are certainly in an area of the world where people are more likely to obey the mask rules rather than challenge them and protest them, which I'm hearing about in other places around the state. But the outdoor mask has definitely become a point of contention. So we have some districts that have said, you will continue to mask outside, and we've had some parent pushback around that. Some districts that have done that, I would say, I would cite a district like Pleasanton as an example that has done outdoor masking requirement and has had some pushback from families to the point that they've had little protests in front of their district office and that, but they've hung tight on that rule. And a lot of this, and there's been a lot of concern around the lunchtime period. And I know that we may talk a little bit more about that coming down, but large groups of students taking off their masks and eating. And so we've done our best to give them, again, a wide array of choices around how they might approach the lunch period. Every school's facilities are the same. Their number are different. Their number of students are different. Their circumstances are different. So there is no one size fits all solution to school, but these schools are, I think, really doing well with the indoor masking and perhaps facing some challenges around the outdoor masking, especially those that are requiring it.
Thanks, Michelle. Next slide. And now on to testing. So there really aren't a lot of requirements for testing. The state puts out some options, which I'm going to talk about on the next slide. But students should be tested if they're sick or if they're exposed. And then staff, per the Cal OSHA regulations, need to be tested if they're sick and exposed. And then unvaccinated teachers and staff must test weekly to comply with the new state executive order. And in some cases, test results are required in order to return to school or work after having symptoms, or in certain quarantines, which I'll talk a little bit about. And most testing is provided, by districts and schools with no cost to students and staff. Next slide, please. And these are some of the testing options that the state has put out. And again, these are options. So the state doesn't really come out with real strong recommendations. Last year, they did have stronger recommendations that were for particular, case rates and that kind of thing. But now it's really like, what works for your community? Here's the options, and partner with the state. And the state has quite a bit of funding that they're using for these testing programs. It hasn't been without challenges, as I'm sure you've all heard. But these are the options that the state is putting out there. These PCR tests, testing, PCR pool testing, and then the rapid antigen testing. And Michelle, if you want to talk a little bit about those challenges and how they're addressing them.
This is, I think we have two. So this last column, personnel support, I think you could draw a big circle around that and talk about staffing and the challenges that schools are having with staffing a testing infrastructure. You can imagine for our larger districts in particular, the idea of being able to roll out weekly testing for a district with 10, 20, 30,000 students is a significant lift. It requires a significant amount of staff. I just want to share that we've got schools right now that are having trouble staffing classrooms, don't have enough substitute teachers. I think the reality is that testing became a thing again really quickly for schools. I think that they left in late May, early June, and we were in a much different place, and testing was becoming de-emphasized. I think a lot of people, maybe beyond some of the school leaders, went on their summer vacation after an exhausting year and said, don't call me until the moment I walk in that building. And by the time they walked back into that building, it was a lot of advice about test, 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 test. And so it has taken, while they're trying to open their schools and reroute their kids and resort their lunch periods and whatever, they're being asked to stand up significant testing infrastructure. The other part of this is that testing is that antigen tests in particular are becoming scarce. I think that there was a slowdown in production. The state is working on recovering that supply. But I think for those rapid antigen tests that people feel really strongly would do really well with schools to be able to tell them quickly whether kids have been exposed or whether they're positive or negative, there's a shortage right now. So combined with all of that, school districts are under a ton of pressure from their communities to institute weekly testing programs. And I can share, frankly, that many of them don't have the staff to stand up a weekly testing program at this point, and some of them don't have access to tests. That is not to say all is lost. It's just been a very quick turn. We're about 4 weeks into the school year from some of our school districts that just started, and testing and building testing infrastructure continues to be a significant challenge.
Thanks, Michelle. And we are trying to support schools in that effort as much as possible. Okay, so the other, this is another kind of piece of guidance that's been challenging for schools. And we wanted to talk about all the different quarantine options. And I'm sure maybe some of you have heard about, before it was, kind of a simple quarantine, the 10-day quarantine or the 14-day quarantine. Well, now there's different options. And one of these options is what they call a modified quarantine. And this means that if this is for, unvaccinated students who are asymptomatic, that they can actually come back to class. So they don't need to quarantine at home. They're able to be back at class if they do testing, twice weekly testing. They need to remain asymptomatic, and they are not allowed to participate in any sort of extracurricular activities, but they are able to come back to class. So this is a quarantine option that a lot of schools are trying to implement in districts. It has been very challenging to track the students, the testing, to have the testing ready. Lots and lots of questions about this, but it is, it is something that districts are in the process and just trying to implement. I think we give a lot of support around modified quarantine, questions all day long around how to do it, interpreting test results. It's very difficult. They get differing, tests from different kinds of tests. And so we're always kind of on the line trying to help schools manage this. This has also been challenging around communication because it's complicated. So parents don't often understand what this means. So we're also trying to help support schools around that. Next slide. And we're almost done here. And this is the shortened quarantine, which this is not coming back to school, but it's a shortened quarantine at home, but you're able to test out of quarantine. If you get that test on day 6 or later, which is actually going to change to day 5 or later, and then you can come back on day 8. But again, it requires testing and the ability to kind of track that testing. And last slide is independent study.
And I'm going to speak to this really briefly, and this is less about public health, but about the realities, the other part of the realities that schools are facing. So the state legislature gave schools 2 pathways this year for education. One of them was in-person instruction, and the other one was independent study as the educational option for this year. And so it is the lone alternative to in-person learning. Districts don't have the option to offer hybrid learning as was done last year. And so schools are adjusting quickly. I can use Fremont as an example. At the end of the school year, when they polled their parents about how many would be interested in independent study and not having their kids return to a classroom, I think they were numbering in the 200 or 300 neighborhood for a district of 35,000. When we returned to school and the Delta variant was surging, they got requests for 3,000 kids to move into independent study and had to move quickly, and are still trying to adjust to moving teachers and staff to those independent study classrooms, and not having enough teachers that want to move into independent study and how to provide that instruction. It's been a tremendous source of pressure on our schools. I'm not here just to tell you all the bad things that are happening in our schools, because I think that, the start of the school year has, kids are back, and that's what we wanted all along, and we know that that's where they belong. I just wanted to share that I think our districts are really challenged right now. I believe the Berkeley superintendent put it best when he said that the personal fuel of a lot of people working in schools right now is very low. And so we've asked always for grace and patience, but I think they need it more than ever, because I think what schools are being asked to do holistically right now is fairly unprecedented, all for the sake of making sure that our kids are back in class. So I just wanted to share some of the circumstances our schools are dealing with, because they are significant, but kids are back in class, which is where we want them.
Great. Thank you so much, Michelle and Lisa. And we have allotted, unfortunately, to stick to their schedule, only 2 more minutes for this topic of discussion. So what I would hope, what we wanted to do actually is to hear from you all reflections upon that, suggestions, advice, particular things that you're hearing in the community that we can really make sure that we are speaking to. When I say we, I mean ACOE and the Healthcare Services Agency and the work that Michelle and Lisa are talking about. In this interest of time, I think we can only take 1 or 2 thoughts or comments. And then I think, Kimmy, what do you think? We can ask folks to put in the chat or email us offline so we can continue the discussion, maybe the next time or offline, yeah?
Yeah, no, I think that's a great idea. And we are going to keep this on the agenda for
Awesome.
a while. So yeah.
That's great. So yeah, I want to make sure we have about 1 minute. I see one question in the chat and it says, is there a COVID outbreak chart? Or maybe that just went through. So are there any comments or reflections on the information that Michelle and Lisa just put forward?
Larry, can I offer something really quickly as a response to that? I just wanted, because we're working with the districts right now. There are many districts that have dashboards, and the reporting of the data has been pretty inconsistent. The districts they kind of took it upon themselves to figure out what categories they were going to report, categories they were going to merge. We're working with them right now to come up with a data set of categories so that people are reporting consistently, so that we can get this information and be able to pull good data from it. If we had to pull that data right now, it would not be good data. And so we're trying to get the districts to report consistently in the same categories so that we can really get some good data to get a good picture of where we are as a county.
Correct. We've got a hand from Keith Brown from OEA. I had my hand up because I was going to ask Keith a question about what he's hearing back from staff and how, just even anecdotally, how folks on OUS are doing.
Great.
Thank you. I did want to acknowledge that about a week ago, I joined Dr. Moss on a tour of Reach Academy in East Oakland, and in that visit, I did see some positive things as far as the students wearing masks consistently, and the cafeteria staff was very organized and had a good system in place. The classrooms had HEPA filters. I just my takeaway from the visit was that in our school sites, especially our elementary sites, they made the most of the resources that they have, but they need additional resources to increase outdoor dining spaces so students can spread out. And it's just, I've seen inequities in the district with access to outdoor dining spaces, canopies for our students, and also just in the presentation acknowledging some of the challenges with testing, and that that's what I've been hearing from our educators, like more resources at the school sites for frequent weekly COVID testing.
All right, so please do not hesitate to put comments in the Q&A and the chat, and we will answer them in between the meeting, and we will keep this conversation going. Thank you, Lisa and Michelle, for that great information. And now I'd like to turn it over to Dr. George Ayala to talk about a COVID survey that the Public Health Department has been doing.
Thank you, and it's good to see everyone here. Can everyone see the screen?
Yes.
Yeah.
Yes.
Great. I'm going to race through these slides. I probably have more to show than I have time to do. And so this is the first time we're presenting the main findings of this survey. I'm really excited about that. I'd like to start with acknowledgements, and a very, very, very special and big shout out to Dr. Liz Maker, who helped create the survey itself, but also did the analysis and the tables that you'll see today. we did the survey because we were interested in learning more about the potential barriers to vaccination and to get some insights about how to address barriers, especially in Black, Indigenous, and people of color communities, as well as other marginalized groups. The effort really started in December. The team, a big team came together from across the health department and even outside the health department. And we looked at literature, we were paying attention to other surveys that were in the field that we knew about. The survey was short, 18 questions, 9 assessing views about vaccine and about COVID, and 9 that asked demographic questions. The survey opened in April and closed at the end of August. And we did the survey in 2 ways. We had a printable PDF that providers could use to take survey responses and then enter them. And then the survey itself was programmed in the Survey Monkey. We offered in English and Spanish initially, but then we opened up to other languages, and you see them there. I think there were 10 total. And then we had a lot of partners help us distribute, get the word out, distribute the survey links, talk about why it's important to collect information. The survey questions included these you see here. Have you received a COVID vaccine? If you haven't been vaccinated yet, do you plan to get a vaccine? And those are the response options we gave people. We also asked a series of questions about views about COVID-19 and the COVID-19 vaccine. Do you agree or disagree with these statements about COVID-19? The vaccine is effective, the vaccine is safe, the vaccine is being rushed out, side effects from the vaccine are not worth it. People have a responsibility to get vaccinated to help stop the spread of COVID-19 in their communities. And if enough people get the vaccine, businesses and schools can reopen. We also asked about influences on decision-making. In deciding whether to get COVID-19 vaccine, what is or was most important to you? Advice of your health provider, advice from other people you trust, being able to get an appointment easily, being able to get it in a convenience place, being able to get it for free, confidence that the vaccine is effective, confidence that it's safe, and other people in your community are getting vaccinated. We also asked about trusted sources for information. Where do you go for information about COVID-19 that you trust? And there's a whole list there that range from community groups, celebrities, coworkers, Dr. Fauci and the federal government, employers, family, friends, the public health department, internet, medical providers, social media, television and radio, other. So here are some of the main findings. First, I'll just kind of share with you some demographics. And it's important for you to know that in this analysis, Liz and I thought it was going to be easiest to understand trends when we compared vaccinated with unvaccinated respondents. So here you see the total number of survey responses that we had from the survey, 937 total. And how they divided by unvaccinated and vaccinated respondents. Here you see the breakdown by race ethnicity. 795 people chose to answer the question on race ethnicity, so we had some drop off there. About close to 50%, a little bit more than 50% of folks were people of color. And mind you, people could check off more than one response, which is why the percentages don't really add to 100%. Here's the age breakdown. We kind of ran through the entire kind of range of ages, but they tend to cluster, the respondents tend to cluster between 25 and I would say 64 is really kind of the main number there. And then, I included this household size because you'll see it come up later. We asked people, how many people they lived with in their home. Overall, a higher proportion of vaccinated participants were Asian or white, female, took the survey in English, and a higher proportion of unvaccinated participants were Latinx, younger than age 18, lived in houses with more than 4 people, and had not been to college. I want to share with you some differences between vaccinated and unvaccinated respondents, starting with the entire survey as a whole. And just really quickly, I'm not going to go through this at length because I went through kind of the views about COVID-19 vaccines and the items that we kind of asked everybody. And these were all statistically significant differences in the statistics that the analysis that Liz conducted. But you'll see that there are important differences between vaccinated respondents in the orange and unvaccinated respondents in the blue. And that's across the board of these main kind of views. Again, in the category of influences on decision-making, big and important differences for the most part, not always, but for the most part, between vaccinated and unvaccinated respondents. And again, in terms of trusted sources of information, significant differences between vaccinated and unvaccinated respondents. And to give you a sense of the magnitude of those differences, I wanted to kind of share with you the proportion of vaccinated respondents who agreed the COVID vaccine is safe was 3.6 times higher than for unvaccinated respondents. Among respondents, the proportion identifying Dr. Fauci or the feds as trusted source for information about COVID-19 was 3.4 times higher in vaccinated than unvaccinated respondents. And so on and so forth. You see the magnitude for the vaccinated. In blue, you'll see kind of the magnitude difference among unvaccinated. So among the proportion of unvaccinated respondents who agreed that the vaccine was rushed out was 2.7 times higher than for vaccinated respondents. And the proportion of unvaccinated respondents who agreed that side effects are not worth it was nearly 9 times higher than for vaccinated respondents. So I wanted to drill down just a little bit to show you what this looked like among Latinx respondents. And again, we see important differences between vaccinated and unvaccinated across the 3 main areas that we were assessing for. And again, we see really important differences between vaccinated respondents and unvaccinated respondents. For example, among Latinx respondents, the proportion of vaccinated Latinx respondents identifying other people in my community getting vaccinated as important for their decision was 4.7 times higher than for unvaccinated Latinx folks. And you can see the magnitude of difference along the orange for vaccinated respondents. When you go to unvaccinated, the proportion of Latinx unvaccinated respondents who agreed that the vaccine was rushed out was nearly 1.8 times higher than for vaccinated Latinx folks. And then the proportion of unvaccinated Latinx folks who agreed that side effects are not worth it was nearly 2.1 times higher than for vaccinated Latinx residents or respondents. Moving quickly because the time is running. I did a similar thing for unvaccinated and vaccinated Black respondents. And again, we see differences between vaccinated and unvaccinated in all of the domains that I talked about earlier. And again, you can kind of see the magnitude of difference between vaccinated folks and unvaccinated folks. here are the unvaccinated folks. And what I want to call out here, the proportion of vaccinated Black respondents who agreed that COVID-19 vaccine is safe was nearly 5.6 times higher than the unvaccinated Black respondents. And down here, similarly, the proportion of unvaccinated respondents who agreed that the side effects are not worth it was 5.4 times higher than for vaccinated Black respondents. If I had time, I would spend more time talking to you about what respondents told us. We gave people an opportunity to write in comments, and they did. We had respondents sharing quite a bit with us. Some of them had to do with supporting mandates, and some people felt really, really strongly about this. And then a couple of people felt very strongly against mandates, and we heard that too. We heard some common reasons for not getting vaccinated or becoming vaccinated. Distrust of government, doctors, and COVID information came up quite frequently, at least in 16 of the responses that we gathered. And there was a general feeling of doubt that folks expressed in this survey. And communications about vaccines was a major theme. 21 respondents took the time to give us their comments about this, including comments about making messages more clear, giving more scientific information and why that's important, and commenting about the amount of misinformation that is on social media that has implications for any of us who are trying to push out factual information using social media, because we have to kind of compete with that noise. They also gave us information about mixed and changing messages from the government, which we have to pay attention to, and then concerns about biased sources of information. And in summary, differences in views between vaccinated and unvaccinated people may be instructive in informing how to tailor messages about COVID-19 and COVID-19 vaccines. Unvaccinated respondents in our survey indicated being most concerned about safety and side effects, and expressed substantial distrust of government and vaccine promotion. Vaccinated respondents reflected a broader range of concerns that can be grouped in 4 main categories: factual, that included safety and effectiveness; principled, including things like people have a responsibility to get vaccinated; pragmatic, getting appointments easily, having vaccines offered in a convenient place, getting it for free, businesses and schools opening, right, as a result of vaccination; and collectivist, info from other trusted sources, other people in community getting vaccinated, and concern for family and friends. And then finally, concerns and motivations differ by race, ethnicity, and so too should our messaging, right? We have to understand, we have to segment our target audiences. We have to understand, how they think about these things, and then we have to message accordingly. And then my final slide tonight is a slide about limitations. This is a convenient sample, so we cannot use this to generalize to the public, the general population. But surveys like these can provide us with some useful clues or insights that we could use when we're messaging to Alameda County residents. Mainly online, this survey was mainly online, but not exclusively. We did some paper and pen, but biases toward people with access to the internet. But we were able to forge partnerships with providers who were able to and willing to facilitate access to the survey in their office and through the internet access that they had. And then finally, our survey efforts in the field came at a time when others were doing surveys, right? So we were competing, and residents may be experiencing survey burnout. But this gives us an opportunity to triangulate findings from across databases. Thank you.
All right, thank you so much, Dr. George Ayala, for that presentation. It got really interesting towards the end, and I know people might have questions. We are at time, but I think we can at least take one question, at least one, if there's an outstanding question that someone really wants to ask.
Will you come back to the next CAG?
I absolutely will.
Yeah, why don't we hold off, or what we could do is maybe any questions that are pending, we can direct to Dr. George, and hopefully we can get back to you all either via email or at the next CAG meeting. We want to thank everyone who attended tonight, especially our interpreters for doing the great job of interpreting for us. Thank you very much. Remember to protect your mental health tonight as well, as the polls begin to close towards 8 o'clock, and don't do much doom scrolling, but always protect yourself. And again, thank you all for joining us, and we will see you all at the next CAG on Tuesday, October 12th at 5:30. Thanks, everyone.
Hey, everybody.
Thanks, y'all.
Bye-bye.
Thank you, everyone.
Hi, team.